be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good evening, everyone. Welcome to tonight's Lung Cancer Living Room, where the topic is, does my tumor have a biomarker? I'm Danielle Hicks, for those of you who do not know. My role here is number one, to be her daughter, and number two, I oversee patient services and support programs for GoTo Foundation. I've been loving my job for a little over 11 years now. So thank you all for coming tonight, everyone in the room and everyone online. I always forget to start with this lady to my right, because I do forget that she is a survivor, and I know all of you know her. I had we had a Lung Can meeting here this last week, and for those of you who don't know what Lung Can is, it's a Lung Cancer Action Network, and it's a group of advocacy groups from around the country. And we have monthly calls, but once a week we get together in this room and kind of talk about how we may be able to collaborate and work together in the coming year. So we just had this group, and one of the big things we did decide on has to do with the topic we're talking about tonight. And what are we calling it? You guys have all heard it: genomic profiling, molecular testing, comprehensive genomic profiling, like next generation sequencing. It's so confusing, and they're all basically the same thing. So we agreed to call it biomarker testing, either comprehensive or otherwise, as in unity, right, as the groups. That was one of the things to come out of it. So it was a great meeting. You want to go?
Well, it has to be comprehensive biomarker testing, because if you ask your physician for biomarker testing, he may only give you EGFR and ALK. But if you ask for or demand comprehensive biomarker testing, you get the whole banana. So you want all of the available markers in lung cancer today. You don't want to be tested for just one or two.
Yeah, which is exactly what we're going to be talking about tonight, because there's ones that we know of, like you just mentioned, EGFR, ALK, and ROS1 tend to be the ones we talk most about, but there are others. And there are others coming down the pike, so we're gonna get there. So at this point, I'd like to again thank Dr. Kelly for coming and talking to us tonight. As most of you know, she's from UC Davis. We've had several of our favorite docs from UC Davis come out here and speak with us. We're really happy to have her here tonight. So I would like you to introduce yourself, if you wouldn't mind.
What do you do every day?
Yeah, what are you even doing here?
Yeah, exactly. Well, first, let me say, you are all awesome and so inspirational to me. And Bonnie, of course, I can't say enough about you. I'm still trying to get the secret out of Bonnie of how she does it all. I really need to know that secret. So every time
I don't do anything anymore, really.
I still need
I
the
just
secret.
get credit for everything.
All right. But I want to say I've actually been doing this for 30 years. So I started my career at the University of Colorado 30 years ago. And I want to say that even 30 years later, I'm still as passionate about what I do as I was back then. And I have a niece and nephew who I'm very close to. I have an identical twin sister. And so her children are really my children, and they are both in medicine, and they're both at the crossroads of trying to decide what they need to do. And so my advice to them is, you have to do something that you're passionate about, because you're going to be doing it a long time. And I tell them my story about how passionate I have been, and they've seen this through the 30 years, that every day I'm just as passionate. And I'm passionate because you are all on the forefront of my mind. Every day I wake up in the middle of the night many times trying to think, what else can I do? You know, how can I leverage something else? How can I, you know, try to do maybe something a little bit off the beaten path that might still be helpful?
So with that, I want to jump in
Go.
to what we're here to talk about tonight, and that is comprehensive biomarker testing. So I would like Dr. Kelly to talk about what is biomarker testing and who should get tested.
Yeah.
So it's a two-part question.
So
And when.
again, biomarker testing is the additional pieces of information that we get beyond just whether you have, I've heard people say adenocarcinoma, okay? So it's beyond just microscopic looking at your tumor under the microscope. We would call that kind of crude today because again, we have such better technology that we can go to this genetic level. And so biomarkers are really the genetics of your own tumor. Just like everybody in the room looks different because of genetics, your tumor is different because of genetics. And so we want to look at the genetics of your tumor, and that's why we call it a biomarker. Now, tumors, again, typically when we talk about biomarkers, we're really talking about the tumor itself, okay? And we're talking about really genes. And so that's where we call it this genetic testing. Don't confuse that though with germline testing, okay? Germline testing is what we do when we're concerned or wanting to know about genes that you inherit that cause disease, all right? That's very, very different from looking at genes in your tumors, and patients do get confused about that. A frequently asked question when you do the comprehensive testing is, well, you know, can somebody inherit that EGFR mutation, okay, or that ALK mutation? Should my family members get tested? And that's not the type of testing we're doing. We're only looking at tumor testing. So I hope that's very clear. That can't tell you anything about your family, can't tell you if you're at high risk for diabetes, can't do any of those things, but we can tell you the most important thing, and that is what is your tumor makeup. So that's what we're looking at when we talk about comprehensive biomarker testing.
Who are we currently testing for these biomarkers?
Yeah. So when I see a patient, the very first question that I want to know is, you know, what you've all said. I want to know, number one, is it non-small cell lung cancer? Because that's about 84% versus small cell lung cancer. So that's just under the microscope. I want to know if it's adenocarcinoma versus squamous cell. So those are the big groups, all right? So all adenocarcinomas, or again, we also call it non-squamous, should be tested in a comprehensive manner, okay? So all the adenocarcinomas should be tested for these mutations, and you've already heard EGFR, insertion 20, MET, and ALK, but we also have BRAF. We have a very rare one that's not seen a lot in lung cancer, but NTRK. Those are now the approved biomarkers. But then we're looking for the other ones, and there's a list of RET is on that list. Also, HER2 is on that list. And there are some other newer ones that are on this list as well. So that list has become, it's a growing list. So that's why you gotta do that multiplex next generation sequencing. Now, squamous cell cancer, unfortunately, we have not been successful in squamous. Does anybody have squamous here? Anybody with a squamous cancer here? No. Okay, but squamous cell, we haven't been successful in finding these driver mutations. That's what we call them, driver mutations. We have not been successful, albeit we've looked, we continue to work on that every day. So for the squamous cell patients, the only biomarker we do is that PD-L1 testing, okay? So PD-L1 for squamous, that's all they get, okay? So on the adenocarcinoma side, we get that NGS sequencing, and we do get the PD-L1 testing too. So that would be what we would do, all right? And again, we want to know up front what you have before you get treated. Now, again, the issues become, of course, is that if you do this tissue test, the tissue testing, it takes 3 to 4 weeks, all right? That takes time, and you're anxious and you want to get started, and we truly understand that. I do think now with the blood testing that we can get, so now we have blood tests. It's the NGS of the blood testing, and there's several companies that do that, and the turnaround time there is only like 7 days. So now there are caveats to both of those, but we're getting better at all of that. Because remember, at the end of the day, it's hard to wait. One of my most upsetting things is when I see a new patient, I have to say, yeah, you have adenocarcinoma, but we have to send it off to get tested, and it might take 3 or 4 weeks to get a result back, and that is very, very hard. So it's really uncomfortable, but you have to let you guys know what's out there. Typically what I tell patients is I say, if you can wait, it's absolutely important to wait to get these results so you don't get the wrong therapy up front, all right? I always tell patients, particularly if they're a little symptomatic, to say, remember, we got this chemotherapy backup plan if you need to go to it, but we'd rather wait to have the results. But if you really are, tomorrow, the next week, and you're just not feeling well, or you're too anxious and you're more stressed out, and you really feel you want to start the chemo, we can do that too, but we try to get the patients to wait when we know that we have a really high suspicion that you're going to have a mutation. Did you have a question?
Yeah, so just a quick thing on that subject. So I was just at the ALK conference down in Atlanta, and according to statistics down there, they're saying roughly 50% of patients, unfortunately, either because of their doctor or their location or whatever, don't even get the biomarkers.
Right.
And then with the 50% that do, the timing goes anywhere from they get test results within a couple of weeks, or sometimes it's like a 3-month process. And so if they can't work on, how do we get the world to understand that A, you need to do 100% testing, and B, you need to get it done in a timely fashion, because, we'll do a biopsy in 3 weeks because we're busy, and then we're going to send it off to whatever, and we'll get those results, and then, I'm busy, I can't see you for a couple of weeks after that, and next thing you know, it's 3 months later, and that's a lot of progression.
Right.
So a lot of people end up going on something like chemo or whatever in the interim because it's just not happening fast enough.
Right.
What can we do to make that better?
Right. So
Great question.
That's a great question. So you may know that all of the societies have demanded that it's a 14-day turnaround time on the tissue to get results, okay, on the tissue. But you have to give an extra week to get the sample to the site. So we need to continue to work harder on decreasing that turnaround time on the tissue. And every company is totally aware of that and working on that. Now, the other thing is because we have the blood testing now, where you can get the results in 7 days. Another thing to ask your doctor is to say, why don't we do both? Okay, why don't we do both and see what they say? Because if you get the answer in the blood in 7 days, you have an EGFR or an ALK, you're good to go, all right? Remember, but if you don't, then you do have to wait for that biopsy result testing to see if you have anything really there. So I think the liquid biopsies are really going to help us make this faster, all right? So I think that is one thing that's very, very important. And all of the societies have really been very clear about, we have to shorten these timelines.
Yeah, we can only be as fast as technology will allow.
Yeah, we can only be as fast.
But I think second to that, and one thing I just want to kind of reiterate to make sure everyone understands between the liquid space and the tissue space is that tissue is still sort of the gold standard.
It is the gold standard.
So what Dr. Kelly was saying is, if they do a blood test and something shows up, you can be sure it's there. But if they don't see something, you can't be sure it's not there. So you have to go back to the tissue for confirmation of whether or not.
Tissue's always the gold standard, absolutely.
Yeah.
This is not, we always want tissue first. But again, the blood testing, I think, has really been a complement to the tissue for us. Or particularly, obviously if you don't have enough tissue, absolutely you have to do the blood test, all right? Or be rebiopsied, and we try to avoid that. So, yes, there's two questions.
So you said, why don't we do both? And I don't know what everyone else's experience has been, but who pays for that?
Yeah.
Because I know that, we've had liquid biopsies done twice, and both times Blue Shield did not pay. And the first time, we never got a bill from Foundation Medicine. We just didn't. And the second time, we had a doctor who said, we need to check it again, and we're going to do it, and if it doesn't get paid for, I have money, don't worry, which was amazing. But, I know everybody doesn't have that luxury, so...
Yeah. But everybody might.
Yes.
So Go To Foundation, we have a program, and it's treatment and clinical trials navigation. And one of the services that we're able to provide as a joint organization is not only a concierge service to anyone who calls in to look for clinical trials that they would qualify for within whatever distance they are looking at, but also access to biomarker testing that we can provide with our partners for free to patients.
And the companies are good at working with you. Most of the time, patients don't get a bill, all right? You get this appeal, but you don't actually get the bill. And so it does get taken care of. That's probably what you got. So at this point in time, and again, if Medicare patients, again, are not, what I've been told is they aren't getting bills. You guys may know more about that than I do.
Well, these are all things we have to advocate for, okay? Because just to go back to the biomarker testing and why it takes so long. When you've had a biopsy or surgery and they have the tissue, the first thing that, you're in the operating room and that goes over here and they have to prepare it and they have to send it to pathology. Because what pathology does is they decide whether it's adenocarcinoma or squamous or small cell or
whatever, large cell
or whatever. So, that's one thing. That's not biomarker testing. Sometimes people get confused.
Right.
They ask their physician, was I tested? And they go, oh, yeah, sure, you have adenocarcinoma. And no, that's not the test we're looking for.
Yeah.
Although that's important. So then the next test where the pathology lab has to actually send the tissue or the blood out and get it done. It's a process. It's a process. Can it be sped up? Absolutely. And we need to advocate for those things. We have to, bring pathology in closer to us and let them know how important it is that they move quicker.
Yes.
Because patients are waiting for that information to get on the right drug at the right time.
Yes.
I know Katerina has a question, but while we're talking tissue blood, I just want to kind of put out there, is one of the reasons that maybe getting both could be potentially more beneficial, and I don't know the answer to this, due to maybe some of the heterogeneity within a tumor itself? Could that be, could there be a benefit to getting a blood biopsy along with a tissue biopsy anyway? Because maybe we don't know where we're going in the tumor.
Well, I'm not so sure about about that. I think the reason to get it is really, in my opinion, is simply a time. It's simply a time. It's faster to get it. Now, again, there are caveats to all of these things, but yes, it's really, to me, I'm trying to advocate to say, I've got this patient, it's really uncomfortable because you want to treat the patient and you're waiting a month, we're waiting a month, we don't like waiting either, we're on your side. So my only reason for getting the blood is to get a result faster to you so that you can be treated. That's my sole purpose.
I only ask because, I mean, how often do we hear, the tissue was no good, it was necrotic, or you hear stories about...
Well, that is, again, yes. So if the tissue is necrotic, it's not going to be sufficient. You absolutely have to get the blood.
Liquid, yeah.
Absolutely. And so we always have to look at the pathology report, and we've advocated for this. But remember, the IASLC, the College of American Pathologists have all said 14-day turnaround time and to make sure that their processes are more efficient. So what I do is, again, looking at that pathology report, I know there should be on the bottom, it should say, there is enough tumor tissue left to do molecular testing.
Yeah.
All right. Again, we've tried to make that standard, and our reports do say that. So I know, or I can tell, I'm pretty good at judging if there's going to be enough tissue to do the test, because that's the other thing I have to tell a patient too. So while I'm telling the patient that, it might be a month, I'm also telling them, but in a week from now, they may come back and say you have insufficient tissue. And that you don't want to tell a patient either. So my whole point is, I'm just trying to get the test results as quick as I can for the patient.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.